Welcome to the operating room at Deuk Spine Institute. It is December 7, 2023. We are performing Deuk laser disc repair. This is endoscopic spine surgery with a laser. And Christmas came early, right, Luis? Yes, sir. We received 3 brand new lasers yesterday. Not brand new, but we received 3 lasers yesterday. And we're testing the first of the 3 out. They come from a very reputable, oh, look at that. All right, let's get the one more shot. Okay. Shot. All right, so perfect. Let's show the audience what's happening here. Our patient has a herniation at number 5-6 disc and 6-7 disc in his neck. He's got neck pain, and show us the tear there. Look at the annular tear. It's that black line. No, not that. There. Right where the arrow is. You can see the tear where the dye is leaking out the back of the disc and the herniation. Perfect. Let's get an AP. So this patient comes to us from New York, Buffalo, correct? Yes. And I can tell you he's already had surgery here, thoracic, just 2 days ago. We fixed 3 thoracic discs. Look at that, perfect. Jordan, show us on that picture there. First of all, show us the annular tear in the back of the disc. You can see it goes across the back of the disc, the whole back. There's 2 tears. Show us the 2 tears. There's one there, and there's another one a little lower down, right? A little lower, come down. There you go, that black line to the right of your arrow, down and to the right. There you go. Yes, now across. That's the annular tear. That's where the pain is coming from. He has neck pain, he has headaches. Thank you, Jordan. So we're here to fix that tear with a laser. We're also going to clean out the herniation. He's probably got about 20 herniations in there. This is our first surgery for the day. It's a 2-level cervical Deuk laser disc repair. Henry, let's show our audience, why do people get so much pain from a herniated disc? What's the source of it? Okay, welcome back. You now, after watching our video, should understand how a tear and herniation in the back of a disc is the source of the pain. It's from inflammation. Turns out that 85% in the lower back of chronic back pain comes from a disc, a problematic disc or 2. And in the neck, it's 90%. We're going to be introducing the dilator. You can see the tip of it is tapered. It's going to slide down the guide wire that's already sitting in my target disc at C5-6. We're going to slide this down. You can see we haven't even, maybe 1 drop of blood. That's all we've lost. The entire surgery is done through a 4mm skin incision. There's no damage done to the body below the skin incision. All we're doing is spreading the muscles apart. And I do that by twisting and directing the dilator down to the spine. I'm already on the spine. Shot? You can see it on the x-ray there. And let's go ahead and count, Jordan, from C2 down so we can verify our levels. 2, 3, 4, 5, 6. So we're at C5-6. Let's get a quick AP view so we can see that the tip of the dilator is actually in the center of the spine where we want it. It's okay to be off center by about 5 millimeters on either side of the midline. You can tell where the midline is by the spinous process. Show us the spinous process. We're exactly dead center. There's the spinous process below at 7, 6, and then there's 5 right there, 4. So we're right in the middle. Show us the tip of the dilator. Right there. Excellent. Show us the guide wire. There it is. Perfect. Could not be going better for this patient. He had a great result with his thoracic Deuk laser disc repair, by the way. He has 100% of his thoracic pain is gone. He had a stabbing pain, like a knife pain, in his back. And we fixed 3 discs 2 days ago. You can see it on the YouTube channel. Just go back and look at the live surgery section and shot, and you can actually see it. Yeah, we don't need inline. We're good. He's got a pretty big disc. So I'm advancing my dilator through the disc. We're going to go all the way to the back where the tear is in the back. Yep. A little bit more, and then we're going to bring the tube. Shot. Yeah, you got to take those pictures, Jordan. Otherwise, I think it's somewhere other than where it really is. Okay, so take a look here, folks. Give me a ruler. The entire surgery is going to be done through this tiny tube. Henry, can you see this tube right here?
Yes, we can.
See how big it is? 4 millimeters. Y'all see that?
Yes, we do.
4 millimeters wide. So this slides over the dilator, and it creates a channel. We call it the working channel, so we can work through it. And that's where the scope is going to go with the laser. All right, we'll take questions.
This first question comes from Josh on YouTube.
Hello, Josh. Welcome to our live stream here at Deuk Spine Institute in Florida.
They said, hello from Ashland, Kentucky. Question. Just had 2 back surgeries, one in May and one in August. Still having leg pain and foot numbness.
Jeez.
Is that something that would be beneficial for laser surgery?
So Josh, first of all, I'm sorry you've had 2 surgeries and you're still suffering. I really feel for you. Nobody should have to go through back surgery and still have problems. I will tell you this, numbness comes usually from a pinched nerve that has to heal. And it can take up to 6 months to a year maximum for that nerve to heal. So the numbness is not as concerning to me unless it's not going away. What concerns me the most about your story is the fact that you still have pain. Spine surgery is supposed to get rid of pain. It should. And if your surgeon cannot eliminate your pain, don't have surgery with them. Could the Deuk laser disc repair fix your pain? Certainly could. But what you need to do is you need to get a new MRI. Tell your surgeon you're still having problems. Get a new MRI done. And then go to our website, and there's a link we're going to post right now in the comment section. It's mri.deukspine.com. It's a free MRI review. I do it with you. I'll spend 10 minutes on Zoom. I'll see where your symptoms are, and I'll look at your MRI with you, and I'll show you what's going on and what needs to be done to fix it. The fact you have pain in your leg is concerning. It may be coming from your back. It may also be coming from your piriformis muscle. That's spelled Piriformis. That's a very common cause of leg pain, sciatic type pain in patients with back problems. So we need to check that out while you're on the interview with us. But thanks for calling in or typing in. All right. We should have a call-in number too, Henry.
It's not a bad idea.
You know? Seriously, a live stream call-in number. 1-800-FIX-MY-BACK. What about that? and then people could call in rather than typing.
That could work. That's definitely more to discuss later on, but
Yeah.
it's doable.
It would go straight to the conference room. Somehow you could, answer it and get it to go on the, on the live stream, and people could call in and ask questions.
Yeah, we'll discuss that as we go.
Yeah,
And we do have another question.
sure.
This comes from Injustice for All. Two questions from Injustice for All on YouTube.
Fantastic. Sure.
First question is, good morning, Dr. Deuk. Nice to see you again.
Morning.
I know that you prefer the inside-out method, but
Yes.
does it make more sense to treat the pathology outside the disc first?
Yeah, great question, Justice for All. Thanks for understanding there's two different options. So, first of all, with the cervical spine that I'm doing right now, there are no two options. It's only the inside-out technique. We start inside the disc, we work our way outside. But for the lumbar and thoracic spine, there is an option. You can go outside in or inside out. Outside in means you're starting in the neuroforamen. The problem with that is the nerves are there, and often it can be bloody, so you won't see what you need to see. If you go to the inside-out technique, number one, any bleeding you get from the epidural veins is gone by the time you get to the epidural space. It's clotted off, which is very important for visibility. You can't operate on something you can't see. Second of all, when you do the inside-out technique, you're actually passing the herniation and you're going past it and pushing it into the disc. So you always see me taking pieces of herniation out from inside the disc. That's important. You don't want to take the herniations out from the foramen, because if you're doing that, you're operating and working near the nerve root. You could damage the nerve root quite easily. So pushing the herniations back into the disc through the tear is the most intelligent and most sensible, and in practicality it works, and it works great, and that's why I've been doing it. Now, mind you, I'll tell you something. Opinions don't matter. What matters is fact. And the facts are, this surgery that we do, the Deuk laser disc repair, endoscopic surgery, we do an inside out. Our patient's pain from the disc goes away. 99.5% of that pain. 99.5. Think about that number. Write it down. That's basically, if you round that up, it's 100%. So we're able, look at that herniation. We're able to get 100% of people's discogenic back pain eliminated with the Deuk laser disc repair. You can't do better than 100%. Okay? You can't do better than 100%. This is fresh off the analysis that I just did 2 weeks ago. I looked at 200. Look at that herniation. I looked at 200 patients that we saw with chronic back pain. Turns out 85% of the patients have pain from a herniated disc, or 2 or 3. The average was 2.2 discs. And when we did the Deuk laser disc repair surgery on not all of them, we only did it on 97 of the 201 patients. So basically half of the patients had the surgery, the other half didn't. Those patients that had it, the 97, our average elimination of, oh, look at that herniation, discogenic back pain was 99.5%. That's incredible. That means if you took 97 people, which we did, and we asked them how much of your back pain did we get rid of, they said 100, 100, 100, 100, 190, 100, 100, 100, 100, 100, 100, 100, 95, 100, 100, 100, 100, 100, 95, 100, 100, 100, 100, and the average was 99.5. So why change something that isn't broken? Why would we want to do it different? So the answer that I'm trying to give you is there's two parts to the answer. One, there's the thinking through it, the rationale why, and then there's just the obvious, which is why change something that is working, that isn't broken. You know what I mean? The old saying, if it ain't broke, don't fix it. It's just that simple. All right. Great question. But for me, it's all about pushing the pathology away from the nerves and the thecal sac. These are all pieces of herniation. and then getting it from inside the disc where it's safer to get it out. Second of all, bleeding. It allows you to have great visibility. Now, I did not develop the inside-out technique. I was taught it. I was taught the outside in, and I was taught the inside out. Okay, Dr. Hegman, I can't remember his, he was a British neurosurgeon who did the endoscopic surgeries years ago when I first started learning. He taught the outside in. And I can tell you, most doctors don't do it for the reasons that I'm telling you. They won't do it. And then most every other doctor does inside out. So I don't even know if it's debatable anymore. I don't think really anybody that's a serious endoscopic surgeon, well, I think there's a lot of people doing what they call endoscopic surgery, this UBE technique, which sucks in my opinion. I would not do it. It's being taught. It's basically endoscopic surgery on training wheels. That's what the UBE technique is. But it's being taught a lot in Asia and India because it's easier for the doctors, okay? Well, great, it's easier for the surgeons, but that doesn't make it better for the patients, right? If you want what's best for the patients, you got to do the best surgery for the patient, not the best surgery for the surgeon. I mean, it's pretty funny that people think that way, you know, but you guys need to know the truth. They're not going to tell the patients, oh yeah, this is a worse surgery, but we do it this way because it's easier for the surgeons, right? What you want is you want the best surgery for you, not what's the easiest surgery for the surgeons, right, Luis? Right. Yeah, if your surgeon can't do it right, don't do it. You know, fuck. I'm a brain surgeon. I don't do brain surgery anymore. Why? Because there's a lot better surgeons than me out there doing brain surgery. I would not do it. If you were somebody that came to me and said, Dr. Deuk, you're the most amazing neurosurgeon in the world, I'd say, thank you. And then you'd say, would you do my brain tumor surgery? I'd say, no. You want the best, and I want you to have the best. You're my patient. So doctors shouldn't just do surgery because they can do surgery. They should do surgery because they're providing their patients the very best surgery available. And the UBE technique is not the best surgery available. It's far from it. It's very destructive. All right, we're just about done with this disc. Probably another 5 minutes. I'm out in the foramen. This is his right side foramen. You see lots of herniations. And that right there is the posterior longitudinal ligament. You guys see that? The PLL?
Yes, we do.
It's right behind the disc, okay? And sometimes the herniation will puncture it and go through into the epidural space right there. So I've got to kind of open it a little bit just to see if there's any herniation. We don't want to leave any herniation. By the way, the laser is working amazing. We just procured these lasers from somebody in Phoenix, Arizona. They were just delivered to our facility, and Luis has done an amazing job of getting them ready for action, as well as Sean. Any other questions?
Yes, this next question comes from And Justice for All, once more on YouTube.
Sure.
Asking, Dr. Deuk, could you treat sequestered disc herniation and central spinal stenosis with the DLDR?
Yes, we can. Yes, we can. We can treat a sequestered disc herniation and spinal stenosis with the DLDR. Folks, remember, we're not doing these surgeries to make the MRI look good. The most I can get of any herniation is about 70%, if I'm lucky 80. I mean, maybe in a blue moon, 90. But no surgeon on earth can get 100% of a herniation. So we're not doing surgery to get 100% of the herniation. Well, why do we do surgery? Think about two scenarios. Scenario one, the surgeon does the surgery and the patient, let's take a brain surgery, for example. Patient has a brain tumor. Surgeon goes in and does a total resection of the brain tumor. Like 100% of the tumor's gone. The only way to do that is to start taking out normal brain, like parts of the brain you don't want to take out. And the patient wakes up and they're a vegetable the rest of their life. But the surgeon had a good result. You get an MRI and all the tumor's gone. But the patient was normal before, now they're a vegetable. Is that a good result? Hell no, not in my book. Now on the other hand, let's say the surgeon gets 99% of the tumor out, right? And then they radiate the rest. But the patient's normal when they wake up, and they're normal the rest of their life. That's a good result. It's not about structural outcomes, it's about functional outcomes. That's what surgery is about. Good surgery gives you a good functional outcome. And the Deuk laser disc repair, this surgery you're watching, gives the best functional outcome of any surgery in the world. There's nothing better. Absolutely nothing better. I've done them all. I've done all the other surgeries. I don't do UBE because I can already see it's destructive, and it's really endoscopic surgery on training wheels. It's meant for surgeons who are not good enough to do what we do. I'm not going to lower my standards just to say I can do another surgery. All right, just about done here. Great questions, though. I want you all to understand that. Sequestered disc herniations mean they're scarred down to the back of the vertebral body. Okay, you're never going to get 100% of that disc out. Nobody can. And the truth is, if you try, you'll kill the patient. So why kill the patient just to have a good MRI result? That's the wrong philosophy of treatment. Okay. We don't do cosmetic spine surgery. Thank you, Dr. Berndes. Yeah. A lot of people think, oh, let's get an MRI when I'm done. Why? What are you hoping to see? I mean, what I want to know is, how do you feel? Do we get rid of your pain or not? I mean, that's what matters. And unfortunately, a lot of people are misled to believe the MRI tells you everything you need to know. It doesn't. It doesn't. I mean, if you're trying to clear an infection, sure, you want an MRI to make sure the infection's gone. But if you're trying to treat back pain, an MRI won't tell you if a patient has back pain or not. Only a patient can tell you if they have back pain. So many herniations. I'm just amazed. This is his right foramen, right neural foramen at C5-6. And there's just a little bit left. A lot of scar tissue here, a lot of scar tissue. But we're just about done. All right, any other questions?
No current questions, but we do have a comment from Josh on YouTube.
Sure.
And
Yeah,
just saying, you treat the patient, not the machine.
Yes, that's right. I treat the patient. You know, it's funny, Josh, you say that, because doctors are always told to treat the patient, but we're not told how to do that. And we're told to use machines and pictures. Look at that herniation that just came out, guys. Check this out. Bring me the blue towel. Can you see this, Henry?
Yes, we can.
Ruler. So I'm going to give you a better view of it right here. Check that out. I just pulled this. This is just one. There's nothing special about it, except that it's at the end, and I thought I'd show it to you. You can see it's not big, okay? Right there. Y'all see that?
Yes, we do.
It's probably, what, 3 millimeters, you know, maybe 4 millimeters. It's not a really big herniation, but the problem is he had about 25 of them in there, all packed in. So when you get all 25 out, guess what? Patient feels better. Symptoms go away. You don't need to get 100%. You just need to get enough. I think that's it. Let's irrigate. We're done with this disc. Yeah, so Josh, we're taught to treat the patient. We're taught to do that. We're told to do that. And the problem is we're not taught how. You know, we're not taught how. And that's something that comes, you have to have a desire to do that as a doctor, as a human. Okay, you can't teach that to a doctor. You can't teach compassion. A doctor either has compassion or they don't. They either want to help people the right way or they don't. And unfortunately, a lot of doctors these days, and surgeons are not known for their compassion, by the way. You know, pediatricians are known for their compassion. But surgeons are a personality type that, you know, I think there's a lot of good to it, but surgeons are very direct, very focused on, a lot of times, results that do not take into account the patient's feelings. And so what I've found is to cure back pain and neck pain, you got to listen to the patients. You got to ask them afterwards, did this work or not? And if it didn't work, why didn't it work? And if it did work, why did it work? So that's what I've done over the last 25 years in my career, but it wasn't something taught to me. It's something I had to learn from other people, how to do it, you know? And that's why I'm where I'm at. And I realize 100%, MRI scans never tell you where pain comes from, never. You show me one MRI scan where the report says pain is coming from XYZ. And the problem is the radiologist can't tell you where the pain comes from. Okay, so at this point we're done with this disc. We're now going to move on to the next disc. And to do that, I'm going to have to take the dilator out of this disc, but first I'm going to take the tube out. So I'm going to remove the tube. Now remember, we've only lost one drop of blood so far. One drop. And I have a lot of Jehovah's Witnesses. They want this surgery because we don't lose blood. All right, so now you can see we're in the disc, and we got number 2. Let's count. 2. Henry, you on the x-ray? 3, 4, 5.
Yes, we are.
6. So we're at C5-6. I've got to go down one disc. This is going to be hard. And we call this the Deuk spine slide because we're the first in the world to ever do it. And I've been doing it for 17 years, ever since 2007. And the reason we do this is when we want to treat more than one disc in a surgery, you have to move from one disc to the next. We got a lot of irrigation in his bag here. I wonder if we can't put the suction on.
Is it full?
It looks like it's going down. Yeah. All right, so is everybody ready? Get a shot? All right, so at this point, I need inline traction on the head from the anesthesiologist. I need shoulder pull, gentle from the feet area, and I need Luis's help. Shot? All right, that looks pretty good. I think we can make this happen. Here we go. We're going to come out. I'm going to pop out of the front of the disc again, that annulus. I'm going to go straight to the front of the spine. There we go. I'm there. Shot. You can actually feel it. Now I got to stay in the middle. Shot. And I need an AP view. Let's get an AP. I've got to make sure I'm staying in the middle. If you go off to the sides, it's bad. If you get off of the spine with the tip of the dilator, it's bad. There we go. We're in the middle. All right, everybody. We're going to start migrating south. You guys ready?
Yep.
Shot. A little, yeah, that's perfect. Shot. Uh-huh. Almost there. Let's get one more shot. I feel it. Shot. We're there. All right, let's get a quick AP, and nobody move. Nobody move. Shot. Quick, quick. Perfect. We're in the middle. All right. All right, so we're good. So I just need everybody to help me for just another second here. I need a good shoulder pull. I need a good neck inline. I need a good x-ray. Shot? Oh yeah, it looks good. It looks good. I feel it. We're advancing. All right, I need you to go a little further south, Jordan. 2, 3, 4, 5, 6, 7. All right, that's probably going to be, I got a re-angle shot. It looks like we're in like Flynn. Now let's do our discogram. Nice job, everybody. Little pipe cleaning action. We'll just hold the questions for now while I do this. This is the hardest part of the whole surgery. Shot. Nice job. Is that the pipe cleaner? It looks like it, right, Jordan? Yes. Chim chimney, chim chimney, chim chim chiroo. All right, what movie? Very good. Who knows? Who said that? Nikki? Shot? Mary Poppins. If you haven't seen Mary Poppins, I recommend you watch it. Take it. We're done. You can see the discogram. Jordan, show us the herniation in the back of the disc. Right there. Nope. The herniation first. There it is. That little shell of black. That's the herniation, folks. Beautiful. Shot. All right. Mary. Oh, beautiful, Jordan. Nice job. Shot. Shot. All right, so we're at the back. That's really nice. Nobody move. Here we come with the tube. Once I get this tube in position, then we can all relax a little bit. So we got blood drop number 2 right there. We've lost 2 drops of blood this whole surgery. Now, if you have an ACDF, anterior cervical discectomy and fusion, instead of this surgery, you're looking at a complication rate of, anybody know? Let's see who's been paying attention. AP? 50%. Nikki. Oh, man. You're ready to be a neurosurgeon. It is 50%. The complication rate of ACDF is 50%. Perfect. Look at that. Gorgeous. So, the complication rate of this surgery is 0%. We've never had it in 800 surgeries. So why would you have an ACDF done instead of this? Plus, why do you want metal in your neck? I don't know. Why? Somebody tell me. The answer is you don't. The problem is people just don't know about this surgery. Shot? Even though we've published it in the medical journals. Peer-reviewed and published. Look it up. Deuk laser disc repair. PubMed. Shot? Here we go. All right, now I got to keep an eye on that tip of the dilator. I do not want it going back any further. Shot? Everybody help me with the tip of the dilator. It looks like the dilator is coming backwards, which is fine. I don't mind that. Of course, I'll have to advance it again, but that's fine. I'd rather it come back than forward. Shot? It looks like Jordan is playing with the windowing of our X-ray. That looks good. I'm going to have to advance the tube. Any more questions?
Yes, we have a question from Tariq on YouTube.
All right, Tariq, I'll take your question. Shot?
They said, "Hi, I am Tariq from Dubai.
Hello, Tariq.
Can the laser be used to treat ligamentum flavum hypertrophy?"
Yes, the laser can treat anything. I've never done ligamentum hypertrophy surgery. So unless Dubai people have a different kind of problem than everybody else in the world, I would say you don't need it done. What I would recommend, Tariq, my friend, in all honesty and respect, is that you do our MRI review, a free MRI review. We don't charge. And I'll tell you exactly what's wrong and how to fix it. But your anybody that talks about the ligamentum flavum means that they're considering a procedure called the mild, M-I-L-D procedure. And we do not recommend the mild procedure. It doesn't work. So I would tell you right off the bat, do not get the MILD procedure. We see so many patients who've had the MILD procedure for the ligamentum flavum, and they are not any better. They're worse. Shot? All right. I think that's the best I can do. So let's see where we are. Great job, everybody. Thank you. We've lost 3 drops of blood. 3 drops. You don't need the mild procedure. You don't need your ligamentum flavum taken out. It will not help you. You will be back for more surgery. I guarantee it. That's fine. All right, here we go. Last disc. 15 minutes, we'll be done. Henry, have we played the Deuk laser disc repair video, how it works?
Not yet.
Let's play that now.
Disc herniations are a common cause of chronic neck pain.
Yeah. All right, welcome back. You can see from the video that the Deuk laser disc repair is a very minimally invasive procedure. We have no damage to the human body except the skin, where we make a small cut. Unlike other surgeries that destroy everything underneath the skin and cause severe damage to your soft tissues, the Deuk laser disc repair does not do that. We literally pass through the disc, leaving it alone, and pass through the muscles, leaving them alone. That's why there's no bleeding, there's no pain. The reason people have pain after open invasive surgery is because the damage to your body. We're a little overexposed, just a little bit. Thank you. You can see that piece of herniation there is calcified. And I don't mean hard calcium like a rock, but I mean gently calcified, lightly calcified. All right, any other questions from our audience?
Yes, we have a question from Canes25 on YouTube.
No, Canes25 is not allowed to ask any more questions. I'm joking.
Canes25 asks, Doc, I'm assuming the ligamentum flavum is supposed to be there for a reason, for structure support. Why or would you even remove it, sir?
Yeah, Canes25, you are correct. The only reason why doctors remove it is because it gives them a different surgery to do that they can market to their patients that they do that, even though it doesn't work. That's why I would never do it. There's lots of spine surgeries being done today that don't work. It's just misunderstanding of the cause of people's symptoms. There's a lot of misinformation. And the misinformation, by the way, is among doctors. It's not just among patients. And the doctors that don't understand what's happening, they come up with these ideas to treat things that don't need to be treated. And that's really the explanation, unfortunately. You understand? I'll give you an example. The farmer has a crop of vegetables, right? A very nice crop of vegetables. And then at night, he comes out and sees the vegetables are dead. They're gone, missing. So the farmer says, oh, I must not be putting enough water on the vegetables, so I have to water more. Okay, but that's not the problem. The problem is that the hogs, the pigs are coming at night, the wild hogs, and they're eating his vegetables. Okay? So it's an example of the wrong diagnosis. In spine, there's lots of that. All the time, people making the wrong diagnosis. And therefore prescribing the wrong treatment. I make it simple for you to understand. And it happens everywhere, by the way, in every industry. The wrong diagnosis happens all the time, right? So what makes you think spine is any different? Why do you think there's so many people with back pain out there? Because the doctors are misdiagnosing the cause and therefore administering the wrong treatment. All right? So that's what's happening. And the procedure called the mild procedure, it was some doctor who thought of it and then is trying to monetize it. And for those of you who don't know what monetization means, it means sell the equipment to do it to other doctors and making them believe it'll help their patients, or at least it's another way to make money from their patients without helping the patients. I mean, to be honest with you, there's so many treatments out there that don't work. Why not another treatment that doesn't work, that actually puts money in your pocket? That's kind of the way spine is today, all around the world. You know, I always joke about it, but why do I have to be the one to discover all these things, how to cure pain? Why hasn't somebody else done that? I didn't set out to do it. It just sort of came with logical interpretation of the results of what I was seeing, treating patients. I was paying attention. I guess other people don't pay attention. I don't know. Part of it is doctors just do what they're told to do, and they never think outside the box. They're afraid to, or they don't have the ability to. I don't know. But, you know, progress, whatever field you're talking about, requires creativity. It requires going away from the norm. And the ligamentous hypertrophy idea is something that people see on the MRI. The ligaments thickened, and so somebody came up with the idea, oh, the ligaments thickened, so let's go do surgery on it. Well, that's the wrong thing to do, right? And that thickening is called ligamentous hypertrophy, which happens, by the way, in every human being. So you might as well take somebody who has a bad back and go and do wrinkle surgery on their face. Just because they have wrinkles doesn't mean it's causing their back pain. Just because you have a thickened ligament, which happens in everybody as we get older, doesn't mean it needs to be operated on. So it's that manipulation of facts for the benefit of the few, the greedy. They know it doesn't work, but they promote it anyway, shamelessly. It's called the mild procedure, M-I-L-D. I can't tell you how many patients we've seen that had the mild procedure. It never helped them at all.
What is that? What's the acronym for? Minimally invasive?
Yeah, it's like minimal invasive lumbar or ligament. I don't know. I forgot what it stands for. Maybe Henry.
Destruction of bone and muscle to get to that ligament out, right?
Yeah, of course you're destroying bone and muscle, but it's less invasive than a full laminectomy, which is why people like it. It's being sold as a internal laminectomy without the big incision, right? But we already know laminectomy sucks as a procedure. It doesn't work. It's garbage. I don't do laminectomy, just laminectomy ever, because it doesn't work. All right, we're just 5 minutes, we're done. This procedure works, and it works every single time. It's never not worked. I have never seen a patient it didn't work. Now, we have 1%, they re-herniate because they do things they're not supposed to do. They don't listen. Sometimes people think they know more than me. I don't argue with them. I just say, okay. Okay, sure, you know more. That's the problem with the internet. People go, they realize their doctors don't know what the hell they're talking about, so then they go on the internet and they think they know more than their doctors, but they really don't. They know just as not enough as their doctors do. What do they say? A little bit of information is a dangerous thing.
That's the description of
Yeah.
WebMD.
Yeah. We're pretty much done. Yeah, you're right. Right? I watched the anesthesiologist. All right, how many cases have I done with you? Hundreds, right?
Hundreds, yeah.
So I can do anesthesia, right?
Well, fundamentally, your knowledge of anesthesia is superior to
I would kill
most
patients.
surgeons.
I would kill the patient. There's no doubt. It's 100% guaranteed. People would die if I was the anesthesiologist.
Not if I trained you,
No, if I just did it because, hey, I've been next to you for hundreds. No, I've been next to the anesthesiologist 2 feet away
Right.
for 26 years. Okay? So can I do anesthesia? I've done 5,000 surgeries. Can I do anesthesia?
Just like
I
I
should.
can't do spine surgery.
Right. But there are anesthesiologists who think they can do spine surgery, or they know they can't, but they do it anyway because it makes good money. And it's better than anesthesia money. Anyway, there's a lot of people out there doing bad things that shouldn't be doing. If you want to know what I think about it, just ask. I appreciate the fact you're asking. We're just about done. Maybe another minute. I got to look over here. Feel free to type up your questions. I will answer them for you. And I'll come over there and answer them face to face. Okay? Thanks, Henry.
No problem.
You see what the laser does, Luis? Huh? You see the pulse wave? See how it shakes everything up? That's why we need it. You understand? The other laser doesn't do that. No, we're done.
Sitting down, please. Thank you.
So, Henry, let's show them this incision.
Of course.
You can see there's no bleeding. We had, okay. You all know the metrics milliliter. Milliliter is a very small amount of blood or volume, liquid. And 20 drops make 1 milliliter. 20. We lost 3 drops. So not even 1 milliliter of bleeding for the whole surgery. This is one of the advantages of endoscopic, okay? So here we come. We're going to come out, take the tube out, and I always hold some pressure in case there is any venous bleeding. We don't want it. We want it to stop. All right, let's take a look here. Can you see the ruler?
Yes, we can.
All right. So here's the incision. Okay, can you guys see that?
Yes, we can.
4 millimeters. 4. Henry, keep this one for our website for DLDR.
Copy
This
that.
picture right here, give it to Sanjay so that he can put it on the website.
Copy that.
All right? No bleeding. All right. Very good. Thanks, everybody. Let's go to a nice testimonial, and I'll see you in 5 minutes to answer your questions. Go take a potty break if you have to. You ready? Luis? I'm Dr. Ari Deuk with the Deuk Spine Institute. We have a patient who just had surgery yesterday. And if you were tuned in online watching our live surgery broadcast, you saw her get 2 discs fixed in her neck. She's had a prior fusion done with an ACDF and a metal plate, so we fixed the disc above the fusion and below the fusion. She had adjacent segment disease. And how long were you suffering with neck pain and right arm symptoms before you came to Deuk Spine to get it fixed yesterday?
Over 20 years.
Over 20 years.
Over 20 years.
And you had the Deuk laser disc repair done. You can see we had to make 2 incisions on the front of your neck. How do you feel after the surgery you had yesterday?
Awesome. Never felt like I've not felt like this, and I couldn't tell you how many years. I've not been able to actually have a normal life due to the pain. Hurting so bad, having to lie down during pretty much after lunchtime.
Do you still have that pain right now?
No, sir.
It's gone.
Gone, yes.
Yeah, your neck is still a little stiff, and you
Yes.
got to get used to that. But you did have the fusion, fusions always cause neck stiffness, and we can't fix that. But the pain we can fix. So the pain you had before is gone.
Yes, sir.
You happy?
Very, very happy. That's an understatement.
Now you have a funny accent because you come from Bluff City, Tennessee. Isn't that right?
Yes.
All right. And why did you travel to Florida for your surgery?
Done a lot of research, and then I found you. Thank God. Greatest blessing that I've ever had. Best doctor I've ever been to in my life.
Thank you.
I can't really put into words how I feel. It's beyond. It's the greatest blessing ever. It truly is.
Well, I'm glad you're doing well. I know your husband is here. He's been very supportive. He was here throughout the surgery yesterday, and you can actually see in the video footage that we made 2 tiny little 4 millimeter cuts in the front of your neck, went down through the neck, not damaging anything inside, and getting to the herniations where the tears were. And actually, you could see the tears on the discogram that I did. And they were big, and we were able to get in there and clean out all the herniations with the laser, and we didn't have to do fusion anymore. We didn't make your neck any worse than it came here with. And the nice thing about the Deuk laser disc repair is it's a stabilizing procedure, getting rid of pain and neurological compromise. I checked you today. You came to us with weak arms, and now you have normal strength in your arms just 12 hours, 24 hours after your surgery.
Yes. Not had that in so many years. So many years.
All right, well, is there anything else you want to say to your fans out there?
Anybody suffering with chronic pain, you have no idea. It is well worth coming to see. Like I said, he's the best doctor I've ever been to in my life. He actually cares. First doctor I've ever had in my life to hug me. and asks me how I'm doing.
And compliments you on your nails.
Exactly. He loves my nails.
I
He
do
loves
love
my
your
nails. Highly recommend him, like I said. Very well worth everything. He truly does care. And the team here is awesome. The nursing staff, everybody was tremendously, I can't express enough how everybody was so good to me and just went out of their way to make sure that I had everything I need. I was comfortable. You know, it was just a very wonderful experience. It truly was.
And I appreciate you sharing. You also had the Deuk plasma rhizotomy, I just remembered, because she had facet joint pain as well as the disc problem. And she was having pain turning her head to the right, weren't you?
Oh yeah, I was having extreme pain. I was turning to when I couldn't hardly turn to my right. It was going down into my right arm extremely bad.
And that's gone.
Yes.
Amen. And it's gone permanently. So I'm very happy for you. When are you heading back home?
Saturday morning.
All right. Well, enjoy Florida for a few more days. You take care of yourself. You've got my phone number if you need anything.
Yes.
All right.
I thank
take
you
care.
so very much.
You are more than welcome. It's my pleasure to take care of you.
Even with my funny accent.
All right. Let's get you out of here, okay? Go enjoy the beach or something. And it's August 2nd, 2023. I'm Dr. Deuk Major. I'm here with one of my patients from Croatia who is here in a t-shirt and flip-flops.
Florida.
That's
You
right.
gotta look good in Florida.
Looking awesome, feeling awesome. So now you had problems with your neck before surgery yesterday. And why did you come to Deuk Spine Institute?
I had an injury when I was 19. I guess that's 23 years ago. And I've always had chronic pain as a result of a disc problem here in my neck.
Mm-hmm.
And I thought someday I'm going to have to get this fixed. Recently, I started getting numbness in the fingers because the disc was pressing on the nerve cord, I guess. And I went to a neurosurgeon in Croatia, and they recommended the vertebrae fusion to protect this area and to solve the problem. And my wife was not satisfied with this recommendation because she had a feeling there was something space age and some new technology out there that could benefit me, and she was certain that this was not right for me. So she went to Google and she Googled the 20 best spinal surgeons in the world, and she read about all of those 20 people listed there, and on there was the Deuk Spinal Institute. I'm not sure where you were in the 20 of the 20.
Probably number one. I'm
yeah, sure. Most likely.
But I do want to say, because we are in the space coast of the United States.
Yes, exactly. Yeah, this is where they launched.
This is space age surgery.
This is space age surgery, and I'm so grateful to her because she was certain that this vertebrae fusion was a primitive, old-fashioned operation that we don't need anymore, and she was correct. My first contact with your people was so positive, and I felt really good and encouraged that this is the right thing for me. So we set it up and got a plane ticket, and I flew here to the Space Coast. We're staying on the beach. My mother came down from Pittsburgh. I'm originally from Pittsburgh, but I've lived in Croatia for 20 years. I feel great today. I notice already my neck feels better and the shoulders feel better, so it's still a little sore, but I can tell it's not the same. So I can tell that there's some improvement. I can feel that in my left hand, this numbness is less already. I know that might take a little time to get 100% improvement, but I feel really good about my decision and really great about, I would recommend you to anybody else who's suffering any kind of disc problems in the neck.
Well, I used to do the fusions for 20 years. I've done 1,000 patients with fusion.
Wow.
And as a matter of fact, you can watch them on our YouTube channel because I've got hundreds of them. And we do them outpatient, where you go home an hour after surgery. But the difference is with fusion, you're putting metal in your spine, you're losing movement permanently the rest of your life. The metal stays in there. It causes swallowing problems, it causes a voice to change, it causes scar tissue, and then it causes adjacent segment disease, meaning you have to come back again a few years later and do the next disc above and below because they wear out faster once you do a fusion. So all of that is is just problematic for patients, and it causes ongoing issues. But with the Deuk laser disc repair, you can see we did a 4 millimeter incision on your neck, tiny. And we went through a little tube to the back of your damaged disc where the problem was, pinching the spinal cord, irritating the nerves. And I used a laser to break the herniation up into little pieces, and we sucked them all out. I even showed at the end of the surgery on the blue towel, you could see all the little pieces of herniation there that came out from your herniated disc. At the same time, we left the entire front of your disc normal and alone. So you can keep using your normal disc that God gave you.
Wonderful.
Isn't that great?
That's beautiful. What made me a candidate for this instead of the fusion?
Well, everybody that needs a fusion would get the Deuk laser disc repair. Deuk laser disc repair, the endoscopic procedure, could replace all the fusions being done in the United States.
Wow.
From degenerative conditions, but not like fractured dislocations. If you get into a high-speed car accident, your spine is barely hanging on, you want to get a fusion for that. But 96% of spine surgery done in the United States is for degenerative conditions like yours. They would all be perfect for the Deuk laser disc repair.
Well, if I may state my humble opinion, I feel you're doing God's work.
I agree.
So I think that what you're doing is fabulous and wonderful, and I'm grateful that I came here and that you fixed me up.
I
So
thank you,
for
and,
that.
and I know you're going to be happy with the results. Is there anything else you want to tell your fans out there?
Yeah, just I'm feeling really good, and thank my wife. I gotta give a shout out to my wife. Without her, I would just take what's there, you know. But
Absolutely.
she really did the research and found the best place in the world to get this problem resolved, and I'm grateful to her.
And if you're ever in Croatia, come and visit
Yeah, if you're
this
ever
guy.
in Croatia, yeah, we're very hospitable over there, and we'll have a good time together.
What are you doing in Croatia?
So I'm an executive coach. I teach managers how to manage people.
Oh, wow.
Yeah.
We may need to hire you here.
Yeah, I see your management style, but you know, everything is appropriate to the setting. So because of the high stakes around here, a different management style is appropriate than wouldn't fit in other places as well. So I have been observing your management style, and I quite like it considering the setting we're in. So
I appreciate you saying that because you're very kind with your words.
Yeah.
My management style could definitely get improved. God gave me certain gifts, and patience and management is not one of them.
Yeah, but the stakes around here are high, so we don't need to have a lot of discussion about things.
I can't have mistakes, you know, because they affect the patients and their outcomes, and that's all that matters is great outcomes.
So I respect the way you're running a good ship around here. People are doing a great job. Your people are excellent. So I should also give a shout out to them. So
means a lot to me. Thank you so much.
Thank you, Dr. Deuk.
All right, you take care.
Yep.
Safe travels back
Thank
to
you.
Croatia.
Thank you.
Okay, hope you enjoyed those wonderful testimonials. Those are some of our patients who've had the surgery. We don't pay them for the testimonials. They basically do the testimonials and want to share their experience. So let's just talk for a moment about what we just did. If this is two bones in the spine and between them is a disc, we went in and fixed the herniation in the back of the disc, but we did it through the front. And the way we did that is we went with a little tube through the disc to the back, right where the herniation is. And then I used a laser to zap away and take out all the pieces of herniation to deflate that balloon. And it went really well. The first disc, C5-C7, we got about 25 pieces of herniation out. The second disc, we probably got around 10 to 15 pieces of herniation out. You could see there was a giant tear in both cases, and we cleaned those tears up, so the disc will now heal. People ask me, Dr. Deuk, when you clean the tear, you get rid of the herniation, will the jelly in the center grow back? No, it doesn't grow back. You're born with that jelly. Whatever you're born with, that's all you got. And then what actually grows back is the wall around the jelly, so the annulus. All right, let's take our first question.
Our first question comes from Wizzy on YouTube.
Okay, Wisey, nice to meet you. Thanks for joining us.
They said, "Good day, Dr. Deuk. Can L4 to L5 disc injury from an inappropriate lifting cause L3 facet joint to get arthritic?"
That's a great question. So the question was, could an L4-5 disc injury, and just so we all know what we're talking about here, this is the lumbar spine, and the number 4 bone would be right here, and the number 5 would be there, This is the sacrum. So you count sacrum, 5, 4, 3, 2, 1. Could a disc injury at 4, 5 cause a facet joint problem at 3, 4? The answer is no. You'd have to have an injury to the L3-4 facet joint in order to have facet joint arthritis or hypertrophy.
Alright, next is a comment from Ali on YouTube saying, "Hi Doc, finally got the thoracic MRI that I paid for myself. Says T4, T5 herniation, but I see more on there. Sending it your way for more expert consults. Thank you."
Happy to do it. And Ali, thank you. But here's what I'd like to do, Ali. I'd like to do either a Zoom call with you or a in-person visit. A Zoom would probably be fine. What I need you to do, Ali, before that meeting is I need you to pinpoint the worst pain in your thoracic area and have somebody put an X. And if it's more than one spot, put 2 X's, or even 3. But try to identify the sharp pain and put your finger on that spot, put an X, and if there's another area down below or above that's sharp, put an X there too. That way I can look and see where the pain's coming from. If it's center, then put it in the center. If it's off to the left, put it a little bit to the left. If it's to the right, put it to the right. But put it at the level and the side of where you're experiencing it. That would be most helpful. Thank you.
Next question comes from Samir on YouTube.
Hello, Samir.
They said, "I have osteophytes in multiple cervical discs, and an MRI report said it was narrowing my foramen. Can you fix that?"
Yes, we can fix osteophytes if it's necessary. What I found though is that most of the time removing osteophytes is not necessary. So we don't just remove osteophytes just to remove osteophytes. We'll remove osteophytes if it's causing you symptoms. The type of symptoms I would be talking about would be nerve symptoms down your arm. I will caution you, osteophytes usually do not cause those symptoms. What causes those symptoms is a herniated disc. For those of you who want to understand that a little bit better, osteophytes, most arm symptoms come from not compression, but irritation of the nerve. About 90% of arm symptoms come from irritation of the nerve. So what irritates the nerve is not the osteophytes. Osteophytes don't irritate nerves. What irritates the nerve is the herniation in the annular tear. It's basically a chemical irritation of the surrounding of the nerve called the dura around the dorsal root ganglia. That's what causes the symptoms. So to fix that, you don't get rid of the osteophyte, you get rid of the annular tear. That's what the surgery is we just did. Now, if you have neck pain, 100%, the neck pain never comes from osteophytes, ever. So removing the osteophytes will not fix your neck pain. Fixing the annular tear will. If you have headaches coming from the neck up, osteophytes do not cause the headaches. The annular tear causes the headaches. You leave the osteophytes alone. If you have myelopathy, where your spinal cord is being damaged, if there's significant myelopathy from the osteophytes, then you have to remove the osteophytes for that. Myelopathy would manifest itself as balance problems, loss of coordination of your arms, your legs, maybe urinary urgency where you're having to pee on yourself if you don't get to the bathroom fast enough, even incontinence. So those are the type of symptoms of myelopathy: coordination, balance, urinary control. And you'd have to have a central osteophyte pressing on the cord. It'd have to be pretty big. It's very rare to see that, very rare. So, long story short, osteophytes are not the cause of any symptoms 99% of the time. But doctors, surgeons like to point out the osteophytes because patients understand them as bone spurs. They're not going to go away with physical therapy. They're not going to go away with medication. They're not going to go away with shots. That leaves you, the patient, with nowhere to go except surgery, and that's how they get you. So it's basically the focus on osteophytes by surgeons is to trap you, the patient, into believing you have to have their surgery to fix you, when 99% of the time they would be wrong. You need the Deuk laser disc repair to fix you.
Next question comes from YZ, once more on YouTube,
Hello, YZ.
asking, is traveling a long distance, few hours after lumbar DLDR safe, as this may negatively affect the newly treated fragile disc?
Yes, YZ. I don't know if I'm pronouncing it right, but you are correct to be concerned. However, we don't have our patients travel a few hours after surgery. We have them stay in the hotel overnight. Then they come back in the morning the next day for a quick checkup. At that point, you can get on a plane, you can get in a car, you can travel to China if you want to. It doesn't matter. We have people flying all over the world the day after surgery, and they do just fine, no problem. Yeah.
Next question excuse me, comes from Canes25, once more on YouTube, asking, I would imagine an MRI is to show you the current anatomy, therefore you try not to limit any surprises when you get there, right?
Yes, Keynes 25. The MRI is necessary for several reasons. Number one, it's going to show us the structures inside the neck, either normal or abnormal, so that we're prepared. We sort of have a map, a road map for getting to where we need to go. Where we need to go, though, is always going to be the herniation and the annular tear, or a facet joint, if we're treating facet syndrome. So the MRI's second purpose is to confirm the source of pain that is diagnosed or suspected or diagnosed on the physical exam. So the physical exam really is what tells you where the pain is coming from, the location on the body, and the MRI is just there to confirm that diagnosis. Would I ever operate without an MRI? No, probably not. I mean, I think that would be considered below the standard of care. I wouldn't have a leg to stand on if I had to defend myself. I would not recommend it. MRIs are so easy to get, so cheap, and they show us things. Like if there was a tumor in there, or a fracture, or an infection, I'd want to know that. The only way you're going to know that is with the MRI. So the MRI is important for excluding other causes of back pain that are far less common, which you need to exclude before you commit a patient to a surgery on their disc. So the MRI is more to rule out bad things, and confirm that it is the disc and nothing else is there, really, that's causing the symptoms. Plus, give us a roadmap.
And last but not least, this question comes from Tracy on Facebook, asking, looking forward to meeting with you. I'm scheduled for next week for cervical and lumbar. I also suffer from a significant great toe pain. Would you possibly be able to perform a DPR during my visit? I'll be there for a week.
Yes, we could probably do a DPR on your toe. If you're coming out for other surgery, perfect. I don't know who your scheduler is, but talk to your scheduler. They'll talk to me. If you have toe joint arthritis, I would be willing to perform a DPR on your toe. Yes. And see if it works. But understand, DPRs on toes are still experimental. I mean, it's safe. I won't do anything that isn't safe, obviously, but will it work? We don't know 100% that it's going to work, but we do believe it's going to work. So I'm happy to do it. I think it's reasonable as long as you have toe joint arthritis.
And that is it for questions.
All right, so great. This surgery went very well for the patient. He has a short neck. I thought we were going to have a lot more trouble getting where we needed to go because of his collarbone, his shoulders, his short neck. But blessings, and we were fortunate. We got lucky with him. We were able to get everything done safely. We lost 3 drops of blood the whole surgery. We fixed 2 herniated discs in his neck. We did it through a 4mm incision. He's in recovery right now. He's probably going to go home or back to his hotel very shortly. Now, he's from Buffalo, New York, and it turns out the next patient is also from Buffalo, New York. He's a young man with his wife. He's been suffering with neck pain. He went to a spine surgeon in, oh, by the way, the patient we just did, I believe he went to the Bonatti. He had a foraminotomy. It didn't work. He's back. And that's why he had a surgery with me. But the next patient is from Buffalo, New York as well, and he had a foraminotomy done in New York at some doctor in New York, maybe specialty hospital in New York. Anyway, it didn't work, so he's here to have the Deuk laser disc repair. He's having the number 5, 6, and 6, 7 fixed as well, but from the opposite side of his neck. And he's having neck pain, arm pain down his left side, and headaches. So we're going to do his surgery next. It'll be a 2-level, pretty much identical to this one except the opposite side of the neck. He has, I hope, a little bit easier neck. We'll see once we get him in the operating room and asleep and we get some x-rays. But he gave me permission to call him Buffalo Bill because he's actually from Buffalo, New York, and he said I can call him Buffalo Bill or Buffalo Phil, but anyway, I just thought that was kind of funny. So we'll see you back in about 30 or 40 minutes for our next surgery. Hope you enjoy.